the heading of the talk was how to do a flawless fixed bearing uni. I've taken it off to a good fixed bearing uni. I think we always try to become perfect, and the journey never ends. So you can't call anything perfect or flawless. We can only do good and better, and going to our best. So this is a quick talk about how to do a good fixed bearing uni. I'm a fixed bearing uni guy. I stopped doing Oxfords in 2012, and since then I've just been doing fixed bearing unis with very good results. It all starts with patient selection, as Jayesh said. You need to select your battles properly. So first, don't even think of doing something like this with a uni compartment knee replacement. Don't start with a patient like this. You don't want to search for the knee joint before doing a uni compartment knee replacement. So always select your battles properly. This is sort of an ideal patient. Ignore the lateral osteophyte, that's not going to come in your way, and that's not an indication of lateral compartment arthritis, but you should have bone-on-bone arthritis in the medial compartment. This is a standard standing X-ray. It's not a Rosenberg view, so they will be graded for arthritis inside, so don't worry about that. A clinical assessment is very important in these patients, so make sure that on table you are able to show that the deformity is nearly correctable. And most important thing is intra-operative assessment. Do not commit to a surgery unless you have confirmed that there is isolated medial compartment arthritis and the lateral compartment is pristine. So this is kind of an ideal patient for a uni. This is patient where I changed decision on table because when I opened the knee, there were these solid track marks on the lateral side which are indicators of ruptured ACL or non-functioning ACL and impending subluxation. So this is someone I would not do a uni for. I will go for a total knee replacement. A basic common things, don't do it in unstable knees. Don't start with minimally invasive surgeries. You should know the instrumentation really well and expect problems if there is scarring, old fractures, if there is too tough a bone or too soft a bone. I won't go through details, I'll just show a quick video. But if you want to do uni, you should know all the steps like this. You should know the instruments like back of your hand. So you should not rely on the company guy to give you the instrument or tell you what to do. You need to know the instrument set really, really well. And you should tell them this is what I need and not rely on company guys. It's very disheartening when I see live surgeries and then the surgeon asks the company guy, "Abhi agle kya karna hai?" That's not the way to do a surgery. You should know perfectly how to do it. You need to see an X-ray such as this. You should see the perfect position of a unicompartmental. This is a tuxplasty here. The posterior spike is perfectly aligned to the posterior cortex. The coverage of the medial femoral condyle is more than 70%. It's well fixed. There is no overhang anteriorly or posteriorly, and there's good fixation. The slope is around 5 to 7 degrees, and that's what exactly you want to do. Now, a common caveat is that everyone goes for a 7-degree slope. No, you should try and replicate the normal slope, and indeed the slope has to be exactly what it was pre-operatively. A lot of times you see X-rays such as this is a bilateral uni done. One side slope looks odd as compared to others, and this was actually flagged by one of the Tux guys to me, one of the company guys. I said, "Sir, the slope is slightly different," and then I sent him the pre-op X-ray. It's a big misunderstanding that the slope is same in both knees. This is our right and left knee X-ray of the patient. You can see the slope is much higher on the left side as compared to right side. So do not measure the slope on one side and say the slope of the patient is X degrees and it will be the same on the other side. It's always different. It's very rare to have the same slope on both sides in a patient. You get good results in patients irrespective of their socioeconomic status, their age, their gender, if you do good surgery in a unicompartment knee replacement. Forget that the same knee that I showed in the beginning as not the right one to start with. You can do a good partial knee replacement on them, and they can get back to action very well. You can see the lady, she's about 4 days post-op. You can see the dressing there, able to start cycling very immediately. The most and the very important thing is always insist on proper X-rays. Someone sent this to me saying the implant is not looking in the right position. All that was required was to get a perfect looking X-ray. So a true lateral view is all that is required in these patients. And if you do good surgery, may it be a 82-year-old such as this, you can expect that in about 6 weeks time, or a 60-year-old guy is able to sit cross-legged, do his puja regularly, able to go back to his normal life, and then show me this at 3 months mark, and you are very happy when you see something like this. My talk is about a flawless or a good uni, so I'll try and show you a quick video if it's okay. I'll try and take the original advice and make it a fast thing. So supine position, side support, foot bolster, like a TKR, you do a normal medial parapatellar approach, take the osteophytes off once you're confirmed that you've got a isolated medial compartment arthritis. Then you do your normal tibial extramedullary jig placement. Quite a few times when the knee is small, you struggle to place the medial pin, so you put 2 pins on the lateral side to comfort, like that. Now the key part is the vertical cut, as I said. So the vertical cut has to be just next to the ACL. So find the ACL, make sure you're not cutting the ACL, and make a vertical cut. Try and do it in slight external rotation. Then you put your minimum size poly spacer on the proximal tibia and take out the tibial biscuit exactly like this. It's exactly 2 millimeters taken off. And as you can see, I'll take a minute more if it's okay. As you can see, you now got a fairly stable knee in full extension. That's the priority. And your flexion extension gaps are fairly balanced if you replicate the slope perfectly. Then you mark the center of the medial femoral condyle and size the femur based on your C-shaped spoons and the sizer. Then you put your femoral placement based on the spacer. This is a tuxoplasty, so you are going to mill the distal femur according to your flexion extension gap. If they're same, you are going to mill till 4, which is the most common thing. So the posterior femoral cut is done. And once you've done that, you are able to replicate the thickness of the implant on femoral and tibial side minimum. Then you do the first trimming and then the second trimming. The first trimming is the depth that you want, and the second was the actual milling to the depth that you have decided to. And once you've done that, you now got a spherical end of the medial femoral condyle, which allows you to place the implant comfortably. This is followed by measuring and then placement of the tibial base plate. Make your keel trial, make sure that your keel is sitting perfectly, and essentially that's your surgery done. So once you're done your implant preparation, it's a standard thing of placing your implants and cementing it, give your local anesthesia, your cocktail injections, whatever you're comfortable with. And that's your implant being placed now. This is a vitamin E enriched poly, so has slightly longer lifespan, and that's your final implant inside. So once you're done that, you are actually satisfied on table in just about 35-40 minutes that you've done a good job, and these patients are going to do well. So if you select your patients properly, if you follow every step as you have intended to, and when you know everything has gone according to plan, you can rest assured that your patients are going to do very well. Thank you.